welcome to the 4th International Conference in Neurology and Therapeutics. And we'll have very condensed program today and several good, excellent presentations included in the upcoming sessions. And we will start with the first couple plenary speakers. With the first one, I'll be doing that. And the second one with the Honorable Dr. Alessandro Morali. He will follow my presentations. That will conclude, after this, will conclude the plenary sessions, and then we'll have a coffee break. We'll be across the hall all the way to the end. And then after that, we'll start the session one in clinical neurology and nerve therapeutics. And Dr. Lamar Siebenherr, sorry about that, Siebenherr. He will be chairing the session. And then after that, for the conclusion of the session, we'll move to the Young Research Forum after the break, and then that will conclude the program for today. Now, like we mentioned yesterday, that we're just going to continue with the program. If somebody is missing or somebody not here, we're going to just keep moving the presentation up, and we may conclude, earlier the session, the next presentation sessions, okay? So that's the advice, people not to leave, because, like I said, this is like as stated in the program, that's changeable. The program is changeable. With this being said, we're going to move on into the first presentation. I would like to share with you the work we've been following for, I would say, a lot of years. Okay, I've been following the development and application of ceramic drug delivery systems. And dealing with the drug delivery system, we always, when you develop a new technology or a new system for pharmacokinetic deliveries, always you look into what is the most feasible application, like how you're going to apply it to conform your device. So from the late 80s, when we start following this development of this drug delivery system, we targeted the reproductive system, reproductive hormones. We said, well, it's easy target. We could prove if the device is working. Just if you work with males, take the testes out and do an alternative or replacement therapy. The same thing with the females. So take the ovaries out, and then you could do, test the feasibility of the device. So this is how I started targeting that. And then when we went there, we thought that's an easy task. And then we saw it's really a complex. We led us, to a lot of issues in there. And the main thing we found that the brain is involved. It's not actually, it's not the ovaries or the testes that control the secondary sexual characteristics in all species, but it is all regulated at the brain level. I remember back then in the Kodachrome years, we didn't have PowerPoint. I used to have a slide with people taking anabolic steroids, and what happened to them, they become azoospermic. So the testes, they shrink, and they become sterile. So I used to have two slides. One of them with the normal testes, and one of from athletes, they take anabolic steroids, and the one from atrophied testes. And I asked the student, physical therapy students I teach, I said, can anybody identify this organ in there? And a student, she raised her hand. She said, I know, Dr. Benghuzzi, what is that? And I said, what was it? And she said, that's a brain. And I said, well, technically it is. So when you look at it in reality, it is. The brain is the regulator for the reproductive functions. So when we started dealing with the ceramic drug delivery system, we wanted to look into an alternative mode of drug medications. Not because we were looking for supplementation of a minute amount of medication to do the job, but we were looking at some of those medications or some of these drugs being developed and you cannot take them conventionally, or they are not that effective. Okay, some of them were banned, some of them were toxic, some of them they for slowing down the progression of cancer, for eradicating infectious diseases, eradicating parasites and things like that. But they were banned because of the issue of toxicity, or you cannot use them in a practical field. Like in another way, you cannot give them every 15 minutes to a patient, to achieve the effective level. So that really triggered the looking for an alternative means. These drugs, they could be effective. Why don't we bypass that pathway and see we could, achieve the effectiveness of those medications? So we thought a good candidate carrier for this is a drug delivery system, and we picked ceramics. Were there any other technologies out there? Oh yes, there were. There were liposomes before us. There were osmotic pump before us. There were the elastic capsules before us. There are many attempts with the polymer material, the beads and the polylactic acid, polycaprolactone, but so many of those, they were there. But all they have major issues. They have major problems, and they weren't really effective in the practical field, especially in the clinical side. So we said, okay, let's look for something really more feasible, more practical. We can use it as a carrier. That we came up with the idea with the ceramic-based system. Ceramic, what I meant by it, is like resemble to the bone material. The base of it is calcium phosphate. Okay, either long bones or teeth, hydroxyapatite, they all have the base, which is calcium phosphate. And we said, well, this has been in use already, the material, not as a drug delivery system, but they use it in so many applications in here. They were in valves, they were the cup and the femurs and the implants is made purely from ceramic material. It's they call it non-porous, highly comparable alumina. That's the cup made from ceramic, and the femur transplant, and been used in replacement bone, artificial nose, artificial fingers, artificial ears, and you name it from there, they have a ceramic base. So it comes in the question and say, well, why we picked ceramics over, especially when you write to Dr. Pence and NIH, they are asking for money. They will ask you, well, what is this? Well, how is it better than what's been there? What makes this really unique over all these systems being utilized or being in practice in there? So we said, well, there are many reasons in there that we chose the ceramics in which the other systems they don't have. Example for that is the electrical properties of the ceramics. They do not conduct electricity. They are very perfect electrical insulators. The second, the ceramics have the ability to store electrical charge. It's, if you will, like, from the basic electronics or physics, and they are like a capacitor. It could hold the charge for a little bit, and you could use it later on. And thirdly, it's the ceramic material possesses the ability to generate small electrical signals when exposed to mechanical vibrations. So they could be all linked in the mode of delivery of a lot of medications. Everything works in the body is like a big motherboard, or like a computer board. Everything is electrical. We are the one explaining, heartbeats. It's the body recognizes it as all we wear, recognize it as a drop in voltage. How many millivolts drop from the muscle and the heart, and then it causes actin, fibromycin, and then contractility and ejection and filling and all of that stuff. It's all electrical. The body is working in an electrical fashion. We are the one we say, so much millivolts means systole, means filling of the heart, ejections. So much millivolts, in the red in the machine means filling the chambers, and so forth. Now, the other property or the other feature of the ceramic material, which we didn't have to worry about, is the biocompatibility. When you put an implant inside the human body or any species, you got to make sure that it is non-toxic and it's bioinert and bioactive. And in our case in here, to add another feature which other system they don't have, like the osmotic pump for insulin delivery, you have to take it out. or you have to refill it. All right, and neural plants, the elastic implants, it's a massacre when you take them out after they deplete their contents. With this, we could develop them that they biodegrade after they finish their release, after they complete the release of the contents of the drug, and they could be, wiped out. It could be eliminated. All right, and then these are the applications of the ceramic material to make sure that people there is no need of worrying about using them as an implantable drug delivery system. They, like I mentioned, used in the knees, implants, used in the shoulder, wrist, fingers, teeth, heart valves, and you name it. These are just some of those. Well, this slide here is showing the history. We've been following this for close to over 25 years. With the new formulation, what we have, we developed that in the late 80s, and we had so many applications in there. Now, is it in the market yet? It's not. But we have recently, signed a contract with a company that they will take over to market, the first batch of drug delivery system. That's after so many, like close to over 25 years and solidifying that. So this is how it started. It started in 1979 by a scientist. That's my boss. His name, Dr. P.K. Bashpai at the University of Dayton in Ohio. He is basically a physiologist, and he was nominated for Nobel Prize 3 times. Didn't get it, but he was one of the top, inventor for the bone substitute materials. And I was in the biochemistry department, and I was coming to him to ask him for a recommendation letter because I took a course with him, neuroendocrinology. That's the course he taught in biological science. I was coming there to ask him for a recommendation letter, and he said, well, why you need to do, where are we going? And I said, I'm going for a PhD in biochemistry. And he said, look, I'm a biologist. I'm looking for a chemist to solve this puzzle for me. And I said, what? He said, I have that alumina thing for bone, and I want to use it as a carrier, but I don't know that much chemistry. He knew a lot of chemistry, but he just tried to brainwash me to come to his lab. So he said, you could take off with this. This is, it could be your field. I'm in the bone substitute, and I'm not in this area, but this is a good carrier. That was his idea. And then I said, well, I thought, this is very exciting, but I'm not a biologist. Biological said, you'll be fine, you do fine. Just take a couple more courses here and there, you will do fine. So he did the job. That's what I'm doing with the PhD students now. Learn from him, all right? And we went in there, and we start, working with the all-cap, all aluminum calcium phosphate. And we try to characterize it from a chemistry point of view, looking at all the features and the factors that they affect the release profile. And then initially, there were a couple master's students, they did in vitro study, a quick study, and then I followed up from there with the, in vivo studies, and wherever I went to present my stuff, always attacked by the use of aluminum in the carrier. Everybody said, aluminum, that causes Alzheimer's. You need to stay away from aluminum. This device is not going to work. It'll never be in the market. You need to stay away from this. So we start looking into an alternative, to take the aluminum out and use something else. I remember the Society for Biomaterials was established in 1992. It's the #1 society in biomaterials worldwide now. I remember I submitted an abstract about the use of TCPL, tricalcium phosphate with lysine, abstracts in there to present it in that meeting, in drug delivery system, ceramic drug delivery system. They sent it back. They knew my mentor, Dr. Bashpai. Actually, he was one of the founders. And they said, well, look, the kid from your lab, he won't fit in this meeting. And we don't want to reject the abstract. He needs to withdraw the abstract because it won't fit. And he said, oh, he worked very hard in this. And he said, we never heard of ceramic drug delivery system. We never heard of a drug delivery system in this form and here in biomaterials. And maybe it's better for him to go somewhere else. And he said, no, don't hurt his feelings. Just put him in. So they created a session called miscellaneous session. And so that was the meeting in San Diego, 1984. And miscellaneous session. They put some lump dust. I remember my poster was next to the bathroom. 2 people in the entire meeting, 4 days, 2 people stepped by and asked about it. From like about 3,000 people attended, 2 people were interested out of 3,000. And I said, well, this is fine. And he kept saying, the people don't know about it. This is a new field. You're going to be pioneering it, this and that. I said, well, we're not going to stop. We're going to continue on. Well, last year's meeting, the Society for Biomaterial, there were close to 3,000 presentations, over 2,000 of those presentations drug delivery systems. Sessions after session, and branched from there. I got into the nanotechnology now, and all drug delivery, in ophthalmology there is drug delivery system, in systemic and metabolic diseases, and sessions after sessions after sessions. That's the society. It started with one abstract. They didn't even have a place for it, and became the place for drug delivery system. It's 25, close to 30 years later. Now, anyway, we continued modifying this. So we used the tricalcium phosphate, and then we kept searching and look at the chemistry of it. We added zinc, and then we said, well, let's use the teeth material, crushed the teeth material and fired at high temperature, and we used it as a carrier, and then we moved on and used polymers, and then from there we used binders, and then from there we used the dual delivery system, how we add, especially for major surgeries, we added, using a release of antibiotics followed by the medications. And then we did the targeted delivery system. We could go inside the tumor and put radioactive material and eradicate a tumor, with a tiny implant. You could even inject it inside the tumor. And then like I said, we continued on with the new formulation now we're developing, hopefully will take over. All right. Now, again, the major features of the drug delivery system, again, is the advantage in which the other system don't have. For example, you will avoid major side effects if you use the ceramic material. You use very small dose as opposed to the celastic capsules. To minimize the peak and valley, the jumping, you see the burst factors with liposomes and other materials. And also you could inject directly. We put I remember one bead, a small bead for DuPont 755, a drug for promoting steroid biosynthesis inside an ovary, a rabbit ovary, which is a tiny, like a tip of your pen. We put medications right in there. So these are the systems we used, material, ceramic-based carriers, the all cap, the original, tricalcium phosphate, bone, teeth, and then bone meal. Bone meal, we took the bone, you buy it from the storage, they use it for gardening and stuff like that. We fired that. We took all the organics out, and we got the pure calcium phosphate from it, and we used it as a carrier. It had some, problems with the mechanical strength of it. And then we used the zinc cap, and like I said, we have new formulations. This is the engineering component, how we make those capsules. So we have to follow everything. We have to do it in-house. So we mix the oxides to form a lattice structure, and then we use those engineering terms, calcining, sintering. Calcining means firing at higher temperature, and then we grind, get the particle size we need, and then we fire again close to the theoretical density, which is after that few degrees from that firing, it become a glass. So you fire it way high, 1500 Celsius, a special oven, programmable oven. So right before you turn it to glass to become highly comparable and non-violent material when you implant that. All right. And this is an SCM showing the porosity of the capsule. We did several studies in this, looking at the resorbability and biodegradations, and we published, significantly in this area. And then here is another project, dissertation by a student, looked into the role of the temperature of sintering, when he changed the temperature of sintering and time of sintering. This is using a tissue engineering focus, using a tissue culture. And again, we looked into the site of surgical implantation. searching for the most effective site for the to deliver the material. So this is, as you see in here, this is subcutaneous. This is subcutaneous. See, the implant is making fibrous tissue around it. This is a rat model. See, that's that's subcutaneous region right next to traumatized bone. Again, in here, these are wound clips. And then here is the abdominal cavity. See the form of, it looks like a kidney in there. There's the liver in here, the stomach in here. But you see the pseudopod of this is loaded with steroid hormones and forms the pseudopod all the way down to the testes by itself. The CC guided by itself. And then you've got, again here, inside the muscle. See, this is inside the muscle, the gastrocnemius muscle. And you see therefore that we cause a defect in here to stimulate healing. And here is a study where we looked at the pro-inflammatory biocompatibility issues of the material. So we had a student, his background a clinician, a cytotechnologist. He did his master's and PhD. And he's the first to quantify the inflammatory mediators and the inflammatory cells in there. So he quantified the macrophages, he quantified the neutrophils and fibroblast formations at different sites. You see subcutaneous, IP, and etc. So that's the first. That's about 16 years ago, and he's a professor now in the School of Medicine at the University of Mississippi Medical Center. All right, and then here is showing you the release profile at different sites. It's showing you the variability in the release. If you put them in the muscle, there will be a slow release, and it's significant. It's subcutaneously a little bit higher. And if you want a fast release, then you just dump them in the abdominal cavity. All right. All right. Now here it's showing the impact. One of the studies we used testosterone and implanted in the peritoneal cavities, IP, and looking into the effectiveness. It's always been a dilemma to induce or to regulate fertility in males. Everybody's staying away from it. They don't want to deal with 250 million sperms. They want to deal with one egg. It's easy to look into for regulation of fertility or contraceptives dealing with the female by working with one follicle as opposed to working with 250 million sperms, making sure none of those will sneak and do, will induce fertility. So with here, it's been, we've got a lot of interest from World Health Organizations for places like they want to control population, China, India, and all those areas. They're interested in male fertility research. All right. So here is we see in here, like one of the studies, what we did, testosterone delivery, IP, induced azoospermic condition. You see, this is the cross section of the seminiferous tubules, and they're completely devoid of spermatids. So spermatogonia, primary and secondary spermatogonia is all depleted in here. They became azoospermic. The animals became azoospermic. When we did the same thing with injections, we couldn't get that. We couldn't achieve that by injections. Now again in here, this subcutaneously, we saw more effective delivery by using IP. This is in the muscle. We saw massive reduction in the sperm count, but like I said, germ cells is still active in that sessions. Now, fibrous tissue formation, we thought, well, this is a different formulation of the ceramic. We make them capsules, we make them reservoirs, we make them matrix, we make them any form. It depends on the drug we need to deliver. And here is like the capsule, the matrix system. And we were studying here, looking at the fibrous tissue formation, when it stops. And that complicated even the issue in there and understanding the ceramic device, because during resorbability, it created that fibrous tissue formation. You see the vascularity around it. So it served, like with time, the fibrous tissue here served as another carrier, another barrier, slow down the release profile. Not just the capsule itself, there is another regulator, which is the fibrous tissue. Now here's looking into the thickness. Again, we quantified, histopathologically speaking here, post-implantation, we quantified the fibrous tissue formations after 3-4 months. We went up to a year to see when is the cessation happening there. This is another proof for the resorbability that they biodegrade. The ceramic biodegrade, and you see this is another dissertation, and the focus in here looking at the particles, you see them ingested by the RAW cells, these like macrophages, and showing the massive phagocytosis in there. And again, this is again another detail looking into different ceramic material in terms of resorbability rate. This is all tissue engineering, looking into a tissue culture setting in here and adding, the different material, ceramic material. And we characterized that. We saw a degree of variability in there. We used them. We went from there after we characterized the device. We used them in many different models. We used them in rats, sheep, monkeys, rabbits, mice. And in tissue engineering, we used them in all of these applications in here, MRC5 fibroblast cell lines, a lung laryngeal carcinoma, and then the HEP2, that's a liver cancer cells, and then we used an MG63, that's bone cancer cells, osteoclast macrophages, we used in breast cancer cells, cervical cancer cell lines, RC, another form of endometrial cancer, LNCAP prostate cancer, and HeLa cells, that's another form of cervical, cervix adenocarcinoma. So we had applications and publication documented all of these and several, dissertations. Now, we got funding, to involve the orthopedic field, so we start following that, by looking into fast healing. As you know, major implants or major orthopedic surgeries, they fail because of the infections. They were looking for something for fast healing. When you change a hip or a knee, it's 99% successful. The failing of the implant usually associated with infections. So they wanted the fast healing, something could stimulate the healing process. So we got involved in that, and we filled the trauma. We did induced trauma in the bone, and we filled them with the many different growth factors. We used a different array of growth factors. Remember, the focus is drug development and application of drug delivery system. I wasn't really interested too much in what you apply it for. It depends on the student's direction, what they want to do, which field they want to pick. If they want to pick oncology or metabolic diseases, or they could get the training into doing so. My main concern is the feasibility and development of drug delivery system. All right? So in here, like showing you, we put different growth factors. We start with the PMP2, we start with OP1, we did even steroids, we did testosterone, we did all of these things. Anything could stimulate the fast bone healing. And we achieved good results in there. And then we developed we got a good grant from ORAF, and with the help of Dr. Tucci, professor in orthopedic and anesthesiology. So she's here with us. You will see her in a minute. And we developed the segmental defect. And what we did, we just cut like about 1 centimeter from the femur in here. And we used the plate they used in fingers in human, from hand surgeon. And we used titanium screws in there, with 4 screws in there. We cut this out. See that? That's the model in here. And this is the only model for segmental defect in animals. And then we put the capsule right next to it, loaded with OP1, osteogenic protein, to stimulate the fibroblast. And we achieved union, filling the gap within about 28 days. We got the gaps filled, and which is by injection couldn't do it. With the bolus of injecting, what they do in trauma, they just unload 10 cc of OP1 paste and fracture bone, but they can't reach really the union that fast. With this, we were able, like 4 weeks in a rat model, we were able to. All right, now we're going back to the brain issue and the applications at the brain levels. Like we said, we know testosterone is secreted from here, from the testes, and we know it's the concentration of testosterone is about 15, 20 times higher in the testes than in circulation. So to regulate, we said, we understand now why people didn't want to deal with fertility in males. They prefer always in females, because the issue of the sensitivity of the brain, the sensitivity of the hypothalamus and the anterior pituitary to the circulating steroids. So We said, well, let's see in here. What induces the negative feedback mechanism? What is the level to induce a negative feedback mechanism? If the level in the testes of testosterone, say, for God's sake, for factitious, you know what I mean, number in there, say 50 nanograms per mil. And if you look at what's effective in circulation to induce the negative feedback, what reaches the hypothalamus, it will be 2 or 3 nanograms. So it doesn't need the 50 nanograms. So we said, wait a minute in here. So we could suppress the testes by shutting down the hypothalamus and the pituitary by just giving it 3 nanograms. We don't need to fight the testes with 50 nanograms. That's in case of, we wanted to suppress or cessation of the testosterone deliveries. And the opposite, of course, for hypogonadal men if you want to induce fertility for replacement therapy. So we said, okay, now we are not going to do like the old-fashioned way, take the testes out, or put a replacement therapy, do what they do in most of the clinical practice in there, take tablets every 6 hours, take tablets every 2 days, they maximize the dose, they do this and that. I said, no, we're going to use some science. Even we have a device in here, we're going to look into we're going to work at the hypothalamus and the pituitary level. Now, we fabricated many different formulations of steroids, and we used the both potent ones, testosterone and DHT, just to understand the science behind the hypothalamic-pituitary-gonadal axis. All right? And from there, we found that you don't even need 4 nanograms. We found like less than nanogram when an adult rat, which is like an infertile man within their 30s, something like that, the hypothalamus, the chromatroph and the hypothalamus, they're highly sensitive to steroid hormones at that level. You don't need a high level in there. So we start, looking at the dose dependency. We looked at many different formulation, release profile, pulsatile release profiles, all different kind of things. We found that within 1-2 nanograms is sufficient. A capsule under the skin, subcutaneously, it has only 5 milligrams in it, enough for 3 years. And will induce what? Will induce a suppression to GnRH, suppression to LH and FSH. All the cascade will be shut down. Said, wow, this is interesting. We're going to call the World Health Organization. We need money. And we were successful to get, some funding to start, looking into expanding that. All right? Now, and then we said, people saying, wait a minute here. You've got to get closer to human. You've been characterizing all that stuff in rodents and small animals, and you need to look into something for a practical sense in there to move to clinical trials. You need to apply it in the larger animals. And that's when I was at University of Michigan, worked in my postdoc in there after I finished PhD in the 80s. Now, we applied the devices using sheep models. It's comparable in weight to human, same, size. With what we're looking for, it's ideal. Monkeys is the best model in there. We used it later, but we thought, to start with the sheep model. So with the sheep model here, Shelley, you're controlling the time. 10 more minutes. With the sheep model, in here, what we did is same thing. What we knew from the small animals, and we castrated rams, and as you see there, and we measured the circulating testosterone, which is undetectable, and castrated rams in here, and then we put like a replacement therapy. See that? That mimics hypogonadal man. A capsule with 40 milligram, and it released, and as you see in here, we went beyond 100. We went like to a year in a sheep. And with 40 milligrams, now in hypogonadal man, they give injections of testosterone, 200 milligrams, like maybe weekly, maybe. People with the pituitary issue, they give shots of testosterone, or they have a pituitary tumors that taken out, pituitary taken out, they take shots weekly of 200, 300 milligrams of testosterone shots. This is 40 milligram was enough for a year to induce effective level of testosterone And these animals didn't have testes. See them, the sheep in here? Didn't have testes. And then we looked into, is this really effective testosterone? Is it effective hormone? Or is it just, what we're measuring in there, a free testosterone, not bound, is not doing any actions. So by looking into testing what? Testing the hypothalamus and the pituitary function. What we looked for is very difficult to deal with the hypothalamic hormone, the GnRH, because it's so minute and it's very difficult to put a catheter in between, the hypothalamus and the pituitary, and withdraw some blood from there to assess the hormonal levels. There's a small project we did in Michigan, in News, where we put that catheter in there, and we left the catheter, the implant, in the sheep, and it was like, a mess. And it was a very, very tedious process. Now, we went there with the pituitary hormones. So we looked in the LH and FSH, and here you go. This is when there is post-castration. It's like, exactly hypogonadal man. The LH is high, the FSH is high. So with the one day getting testosterone, we managed to suppress the LH levels. See that? All right. Now here is show you the differential. This is an example of 3 sheep and show you the sustained delivery. See the release profile? It's almost sustained. We can't say controlled release. It is sustained levels, and this is a physiological level in the sheep, and that was effective. Now, and then after that, we went to more challenges in there. More challenges in there. We said we were challenged, and I remember one of those endocrine meeting. Those are big meetings in the U.S., and we're challenged of developing a dual release system. And like I said, we got the first funding for bone research, and we did antibiotics, and we put like gentamicin and vancomycin and tobramycin. All of these we tried to use in the clinical field, and we added, and then the growth factors, different growth factors. And then we're challenged with, what about we get more, applications looking into induction of fertility in non-breeding season. Like in sheep, the sheep, they breed from November to February, and then after that cessation will be no estrogen and progesterone, completely very low or undetectable. So we said, well, can we induce a estrous cycle in the middle of the summer by having a cyclic activity in there? And that's what we'll be talking about tomorrow. We have a presentation tomorrow to talk about this challenge in here, inducing like an estrous cycle, which is mimic like a menstrual cycle exactly, with like no ovaries in there. All right? Okay, and then we looked into more in cardiovascular research in here, like you see in here. We looked at, this is the heart tissues. We used the anabolic steroid. They used, the athletes, they used the androstenedione. It's banned now. And we looked into the induction of myocardial necrosis, and we're first to report the secretion of the cytokines. We're the first one to, because of the good biochemist we have in our team, Dr. Tucci, we're the first one to fractionate and also isolate and purify and identify the several cytokines, mainly IL-1, IL-6, and tumor necrosis factor. All right? And that's more of those cytokines. And then we had a project, we looked into the prostate. That's another issue too. This is Dr. Pollan's dissertation. She's a professor now in Georgia. And she looked into the induction of benign prostatic hyperplasia from using anabolic steroids. So she went looking into all, she did histopathology from the hypothalamus all the way to the prostate and looked into the feasibility of that. So with this being said, this is a list of several of the PhD students, a couple of them deans now, a lot of them chairs at departments, and you name it, they're all successful people in there. And with this being said, that concludes the presentation in here. It's very difficult, to put, somebody come to you and say, well, can you summarize your 300 publications in 15 minutes? So that's the major challenge. Then sitting down and develop and give me a drug, and I say, I want you to deliver this drug inside the breast cancer, and I want you to eradicate this. This is the level I want you to do, and I want you to make me a capsule for 3 months. That's, to me, is a piece of cake. But you say, well, can you summarize what you did in 30 years in 15 minutes? That's a tough project. I hope I did, my best in that, and thank you for listening. All right, now it is a great honor to introduce our speaker from